Hello everyone. Today's class we are going to discuss about the remaining part of hemolytic disease. So start with thalassemia, B-Thalassemia. So it is an inherited disorder of hemoglobin synthesis that results from an alteration in the rate of beta globin chain production. So this is also a blood related disease and which is occurs because of hemoglobin disorder. And now we are going to see the pathophysiology of thalassemia. That is, first, abnormality occurs when there is a defective production. So when there is a defective production in the hemoglobin, that time only the abnormality will start. Production of beta chain and excess of normally produced type which accumulate in the cell and unstable. So it means when the normal hemoglobin or normal RBC production will be not there, that time only the beta thalassemia will start. Next we have the types of thalassemia. There are two types, one is minor, one is major. So when we will call it is minor thalassemia, when the reduced production of beta chain, that time when the beta chain reduction will be reduced, that time we will call it is a minor thalassemia. But when there is a complete absence of beta chain production, we will call it is a major thalassemia. Next one is type of expression in thalassemia. So there we have three categories: thalassemia trait, thalassemia intermedia, thalassemia major. So in that patient, first one patient have mild anemia. In the second one, the patient have intermediate anemia. And the thalassemia major, the patient will have severe symptoms like anemia and hepatosplenomegaly and the weakness, and there is a disturbance in the head and that maxillary prominence. Next we have management of thalassemia. So first option is blood transfusion to keep the hemoglobin between 9 to 10 mg per dl. Then chelation therapy and iron overload. After multiple transfusion, patient may develop iron overload, so leading to diabetes, thyroid and parathyroid dysfunction. To remove excess iron, chelation therapy is very effective. Defromaxim IV subcutaneously or alternative defropron per oral we can give to reduce the iron level in the blood. And why there is iron level increase? Because they are going to give the transfusion of blood, so it can raise in that increase iron level. So for that also you should go for chelation therapy. So this is the management for thalassemia. The next hemolytic disease is sickle cell disease. So it results from substitution of valine for glutamic acid at position of 6 of beta globin chain. Sickle shaped RBCs are rapidly hemolyzed and have lifespan of 10 to 20 days. So this is in this picture you can see that how the sickle cell shape. So normally this is our normal RBC, but this one is sickle shaped cell. Next, presentation or clinical symptoms. Hemolytic anemia developed after 2 to 4 months of age, and in that the baby will have pallor and jaundice, and asplenia due to auto-infraction of spleen. Spleen not palpable after 6 years. And what are the diagnostic evaluation we can do? That to know the anemia and thrombocytosis, you can go for normal blood test, normal MCB, bone marrow hyperplasia on bone marrow, aspiration, sickle cell or Howell-Jolly bodies. These are the diagnostic factor. Through that we can find out that the baby is having sickle cell anemia. Next we have the management for sickle cell anemia. The first one is hydration. It may be per oral or IV. Then analgesics or narcotics. Then specific therapy. Aplastic crisis, that is blood transfusion may be necessary. Then in case of acute coronary syndrome or cardiovascular effect, it requires oxygen, mechanical ventilation, and many requires exchange transfusion. Next we have preventive care. So after 2 years of birth, the child is kept on penicillin and amoxicillin and folate supplements, immunization against staphylococcus pneumonia and hydroxia, that is increased HBV level. So these are the preventive measures to prevent sickle cell anemia. With this we have completed all the hemolytic disease. Thank you everyone.